desktop. There's presentations, and that is empty. Ah, Sunday's even better. And one more click. Thank you. Greatly appreciate it. It's a privilege to be with you today. Toby really is on his way. So soon you will be rescued. Toby and I have worked together for a long time. He serves as the Chief Medical Officer for our international division collectively. I do the outcomes research both domestically down south as well as internationally. Just came back from tours in our client base in Australia, in Singapore, and in the United Kingdom. And just kind of some fun. This is our entertainment for the afternoon. Can you name those flags? I think one of the things that's fascinating is in Canada, there's a great loyalty to the King and Queen and to the flag and to the Union Jack. But many of us in Canada and in the Commonwealth, as old members of the Empire or current members, don't really get the Union Jack. When it was first invented in 1606, it only had the red cross, this one, and the blue background cross, not the red X. That was because that red cross is St. George's cross, right? Which is the flag of, and the blue background with the X is St. Andrew's cross, which is Scotland. So the United Kingdom was the two. Then Ireland was incorporated as part of the United Kingdom, and so this one was added, and that would be St. Patrick's cross. Thank you for all the participation. And so as we were getting ready for this, so what happens next if Scotland decides to vacate the United Kingdom? Well, there's already, we found on the internet this morning, a planned flag potentially for the new Union Jack, which will be the fourth in that generation, and the blue background will disappear, and down here at the bottom will appear a green shade and white all on the top, because the flag of Wales is white and green with the griffin. I can probably quit now, right? You guys are difficult to entertain. The major point being, I've been in and out of so many different healthcare environments, different governments, different financial systems, different models of delivery and training, and yet I keep learning the same lesson. We seem to be more similar than different. We find 5 key trends that we consider to be the megatrends, the big preoccupations across economies. No matter where we go, we seem to be worried about the same things. We solve them a tad differently, but today our conference is mostly about technology. So what is the relationship between the similarities and the differences and the evolution of technology? In the C-suite, the leadership level of these organizations and these economies, the same kinds of worries seem to keep people's minds occupied. I look at things like HIMSS analytics, which sounds very domestic down south, but is bleeding throughout the universe because every economy is looking for a better way to measure and therefore create accountability for improved care as costs fall. One of the cool things about the budget constraints, and this is a great concept, so this will be the second only thing you need to remember from my contribution today, not counting the Union Jack as the first. In England, the national health system, they have this really cool concept. This is your budget for the year, right? The pie. if you can save some money in that slice, you can use it somewhere else, right? They call that cash release. So instead of saying cost savings or reimbursement better, they tend to refer to it as, is it cash releasing or not? Meaning, does it give me real money that I can use somewhere else? Neat concept, huh? So that's two things of value. Hopefully there will be a third or a fourth. And this of accreditation comes home to us today. I would propose to you that Canada has one of the most mature, as well as one of the more demanding and bureaucratized form of accreditation of any of the healthcare systems in the world. That maturity works both for us, but it is also onerously difficult to meet the needs. Clinically, we seem to be more similar than different. It still comes down to a mommy and her child visiting with a good clinician to get a solution to a problem where we go from sick to less sick. That patient-clinician interaction is the basis of healthcare throughout the world, no matter what the economy. Therefore, you see the fifth bullet, this thing about engaging patients in maintaining their own care or in being more correctly responsive and compliant to best resolution to care problems are key issues. Another key issue is access. You don't have that issue nearly as grievously as other economies do. The ability to find care and then be able to leverage it for the good of us and those we love. The shortage of general practitioners. South of the border, that's in part because physicians tend to subspecialize, right? So you don't go into general practice because it's more lucrative or challenging or exciting to be in a specialty. Throughout the remainder of the English-speaking world, it's just hard to find sufficient doctors who have chosen that profession, and therefore general practice is something that's openly available to all of the populace. And then I can't ever resist this conundrum, this paradox, this challenge. We keep wanting to use medicine to live longer and better, and then we bellyache that old people cost too much to take care of and are not contributing anymore. You want me to say it again? Can you do yourself a personal favor? See it when you do it and quit? You can't have it both ways. And the entire civilized world, English-speaking world, is faced with that same conundrum. I want medicine to help mine live longer and better, but I don't want to be paying more and more for what we call an unsustainable system, which that's political talk. And in terms of the general public, now most of us here are clinicians or are directly associated with clinical organizations, but for people who are not, or when we wear our other hat of being a normal citizen, we worry about things. I want more control of the health care I get and those who give it to me. I want a national health system that I can have general access to, preferably for nothing. I want better integrated care. I don't want to have to tell the same story 3 times or have someone make a mistake because they didn't know the history before that or the full picture. And I want to not get sick. Second great conundrum. But I still want to have all my bad habits because they're mine. I want to overeat when I want to. I want burgers instead of a salad. I did it last night. Actually, I got both. And by the way, if you do get a salad with your burger, they cancel. The salad trumps. And as I tell my wife, she says, don't eat fried food. And I said, don't worry, it was fish and chips. Because it has fish in the name, it's good for me. Yeah, anyway. We want to be healthier, but we don't want to pay the personal price. And so governments try to tell us how to be healthier, and the governments try to require our doctors to make us healthier, and yet we still have our personal freedom to be as unhealthy as we choose, generally with no financial repercussions. You don't get fined for not taking good care of yourself. Some insurance plans, we know, and this is global, have begun incentivizing better behaviors. If you sign that you're not a smoker, if you click the box that you don't overeat, if you weigh only so much, then your premiums may or may not go down. However, the monitoring of personal behaviors versus the volunteering of the result of personal behaviors are very different and are not globally developed yet. So the connection isn't fully there. The national health system in the United Kingdom is probably the most mature in terms of addressing the needs of patients becoming engaged in their own care and the requirements associated bidirectionally, both patients and practitioners. Good place to look. Quality and outcome measures are all over the board, and yet I got to tell you, and outcomes research, quality measurement, that's kind of my own thing. Much more similar than different across the different English-speaking economies. We know what to worry about. We know the things that cost way too much or happen way too often. And we're doing things to try to measure them better and incentivize organizations and practitioners to better address them. In the case of Canada, the triple aim model seems to fit. It seems like across all of these economies, the things we worry about can be summarized into these three categories. I want better care, but I want it to cost less, I being the taxpayer as well as the individual patient. And I want better health, I being the taxpayer who has to pay for everybody else's bad health, and I being myself who wants my loved ones to have a wonderful life. Those, by the way, we often here north of the border, and I'll say also down under, and I'll say also across the pond, have a certain degree of legitimate resentment of the morons to the south. That did not get hardly any laughs at all. There really is kind of a thing like, why don't you guys get your act together and do it right? Because we're doing it better. And then behind closed doors, how can we do it better? Because we're not doing it as well as we'd like. Each economy says that. But this thing of the triple aim, that was actually the foundation of what became called meaningful use to the South. And it has been incorporated in a staged effort to get information technology integrated into healthcare in order to achieve these three goals. The approach came in 3 stages, and I realize most of you know this, but it's still kind of fun to think back on. The approach came in 3 stages. The first stage was supposed to get frontline caregiving clinicians engaged in using technology to improve continuity of care, immediate outcomes, and the exchange of information. The second stage was to make that information exchange more real, to actually move data back and forth, including to and from patients. And that's why it keeps getting delayed, stage 2. It keeps slipping the dates by which the accountabilities and incentives will be offered, because that communicating to and from patients is a little tricky. And then the third stage, which has not hit yet and it's been delayed twice now, will be all about what did it achieve. See, you can do the first 2 stages by checking off boxes on a list. I can, therefore I get. And the federal government gives you some money because you proved that you can. But you don't have to prove that you can all the time. or do all the time, or that it made a difference yet. Is this all helpful, making sense? And that, again, is part of meaningful use and a great model to be emulated. And in England and in Australia, every time I go, I get more detailed questions about meaningful use and what we should adopt from it and what we should help to not go wrong by trying to adopt from it. Did that make sense the way I stumbled on it? The quality domains seem to be universal. We worry about patient safety. Not just did you get better, but did I make you worse? Right? The never events, the avoidables. And we want efficiency of our utilization of resources. We want to be able to take care of more patients, more cost effectively and clinically efficaciously without adding bricks and mortar or staff. Be better with using what we have. And meaningful use has criteria that were based on each one of those 6 different elements. You also have heard of the core measures, and I'm sure many of you are engaged or have informaticists that's just about all they do, is measure, did we meet all these different requirements? The Institute for Healthcare Improvement, IHI, developed bundles for a lot of these, and many of you have instituted those bundles. Do you remember the VAP bundle? Anybody? Can anybody spell VAP? Ventilator-acquired pneumonias. And now they were changing it to ventilator-acquired complications. Have you heard about that yet? See, this is cool stuff. This cutting edge of clinicians understanding things that really matter versus the things that used to be just easy to count and score. Very cool. Those core measures are now virtually global because of Joint Commission International. And every economy in the English-speaking world who has chosen to understand quality has chosen to understand Joint Commission because they have operationalized how to best count things that matter and watch them as they improve. Population health. Okay, I'm going to be a little bit candid on this one. This one kind of makes me just a little crazy. I think we all knew what we thought it meant. In my opinion, what it's evolved to is anything you want to sell nowadays, you can just put population health in the name of it, and then someone will be interested and might buy it. That was capitalism humor. To me, it's a moving target of definition. And yet, to me, as a seasoned health management theorist and health management measurer, this is overwhelmingly clear to me. Population health means taking care of large numbers of similar disease processes in the same or beneficial manner, and keeping large groups of definable sub-elements within societies healthy, both treatment and non-treatment. And much of the press today is all about the magic of population health. What it really means is something between community health as an ongoing continuum and chronic disease management as one of the main elements in maintaining health within communities. The coordination of care teams, as you can see, is absolutely seminal to this. And you know that in the organizations where you live. And big data, which is another sexy term floating around these days, means the analysis of large population-sized data, regardless of where care was delivered or where the patient may or may not live, in the ability to understand larger schemes of what we can do better and is it working better. So with that in mind, we jump to financial measures. And again, one of the conundra, right? How do you deliver it cheaper and better? It just doesn't seem to work for cars. It doesn't seem to work for clothing, but it'll work for healthcare. Actually, the reason I believe many have come to really believe that can happen in healthcare is because there's a belief that there's a lot of waste, that a lot of process is done poorly, that we don't do the right thing the first time every time. That is why we're here together today. What is it that we can add to the system that will make it easier to do the right thing first time every time? Universal health care coverage. This is a fascinating map. If you can't read the writing, that doesn't matter. It's an intuitive one. It shows you that underdeveloped nations, like in the subcontinent and in much of South America and in much of Asia, don't have universal health care. Most of the civilized or developed nations in the world, in fact, arguably all but one, do. And I don't think we need any more. That's the best laughter I've gotten from you all afternoon. Fascinating, isn't it? Regulatory requirements. These things of do better with less. What does do better mean? Well, those bureaucracies and governments that want us to do better or are paying the bills and anticipate or expect us to do better have developed these requirements. Australia has its requirements. The United States, the United Kingdom, and in Singapore, where I also work, each of these 5 seem to have much more similarity on their requirements than they do differences. And in terms of government incentives, and this is a fascinating one, and if you can't read the small type, that's because you need better glasses. Okay, that was ophthalmological humor. To keep classifying it. It's fascinating how many governments are literally investing in creating the information technology infrastructure that will be required or needed in order to achieve these goals that we've been going through slide by slide by slide. The top 2, as you can read on the far right there, are first the United States. And it'd be really fun to see these in per capitas instead of total. But $19 billion in the United States. England is second highest, or United Kingdom, with $12 billion, which is substantially bigger on a per capita basis. And with this slide up, I'm going to turn the time over to Toby Samo. Toby's a dear friend of mine.
This is what you call a friend stepping in for you. Please, let's give Steve a hand.
Toby and I have known each other for years. I'm a huge fan and Chief Medical Officer for the International.
And so I like to describe people to Steve to people to say this is a really unique combination. He's got 2 PhDs, one of them in statistics, and he has a sense of humor.
But I always have to explain it.
Yeah, explain it to me.
That was statistical humor.
So my apologies. As you can see, I feel like Gilligan from Gilligan's Island. It was supposed to be a 3-hour flight, and this is 20 hours later. two canceled flights and 5 reservations. Anyway, I'm happy to be here, and I again appreciate Steve so much for pitching in really at the last moment. And I understand you've eaten, so at least I know I'm not between you and the food. But I do understand that I don't want to talk too loudly so I don't wake anybody up. So as Steve said, this is just like a relay race. He just handed me the baton and I have to keep on going. And we got, 15 minutes? 10? Okay, great. And I'll leave a little time for questions at the end. So, yes? Is that conundrum?
Wow. You see, you get a couple of degrees and things get skewed.
Right, and I have to keep on reminding myself that data is plural or singular. That's right, it's plural. So as Steve was saying, I know none of you can read that slide, so therefore I can make anything I want out of it. But the idea here is that regardless of where we go, across developed countries, we see that there's a huge amount of money being spent on healthcare information technology. Healthcare, I should probably make it broader and to say to improving healthcare wherever we go. And I mean, some of the numbers are astronomical. I mean, in the United States, depending on how you look at it, anywhere from $20 to $35 billion, with a B as in boy, going towards encouraging the implementation of healthcare IT. And why do governments, why are they putting that type of emphasis on it? Because as you go ahead and look towards what is the future of medicine, it is all of the things that Steve has spoken to about up until this time. But in order to get there, we are going to be unable to attain those levels of increased quality, improvements in efficiency, involvement with patients without the use of healthcare IT. So the technical aspects that we see internationally, and I assume Steve also pointed out that when you look at that, there's probably going to be nothing in here you're going to say, oh, I didn't think about that. And that is very much the point. But with many different technical issues that are universal. Integration and interfacing. We do not have a single, and we never will have a single computer system that will, run healthcare IT, and therefore there will always need to be integration and interfacing. And so to have a system that is open, that is able to be, to be able to connect and communicate and be innovative as new problems come up. All of that integration, interfacing, and interoperability is important because if you can do that, then you can share data. And sharing data is key in many ways. And I'm a physician, so always the clinical reasons for any of these things are first, but we have to look beyond that as well. But by having data sharing, we can improve patient care. You have continuity of care from one venue to another. There is a lot of talk about sharing nationally across within a nation, although really most of healthcare is local. Now, local doesn't mean just your individual primary care doc or your individual group of doctors. It is a group, a community that exists within your area. Moving, the percentage of healthcare that is involved of moving from one region to another is limited, although we are now seeing a lot more of that. Medical tourism has become a big issue. There are, some hospital systems that are being built just to attract, attract patients from outside the area. And so the more we can share data in those situations, the more we'll be able to facilitate the expansion of healthcare in a much broader way. But in order to do that, that takes a lot of leadership within the healthcare IT area. And I think all of you here will understand when we start talking about resource shortages. Within information technology in general, there's a shortage of really qualified technical people, and I shouldn't just say technical, it's really that whole both technical and implementation and people that really understand the entire environment of a given area. So there's a shortage of healthcare IT resources in general, and then when you get into that subpopulation, which you are all a part of, there's even a much smaller pool of people to get that you can bring into that area. The HIMSS-IMRAM level, the EMR adoption model, the HIMSS levels 1, 2, 3, 4, 0 through 7, we're seeing a lot more interest in that. You know, my feeling about that is it's an important you know, target, but it's not the actual ends. A lot of the things that it asks you to do in order to reach those higher levels are things that make you a better institution so that you can supply better care. But if you're going after it just so that you can have the shiny object to say, I've done that, then you need to reprioritize. Mobility is getting to be huge. As I was in the cab rushing down here, I, of course, you know, pulled out my phone and said, how much further are we? How much further are we? And so we know how much we use our smartphones, our tablets, regardless of which platform it is, and that is having a marked impact on healthcare information technology. And interestingly enough, having perhaps even more of an impact in undeveloped countries. There's a lot of, not just anecdotes, but you know, good information about how undeveloped countries that do not have an infrastructure are using mobility, using cell phones, smartphones to be able to deliver care and send information. So that is really a global trend. Oops, I moved forward. On technical areas, I'm not going to go into, but the importance of having redundancy, high availability, because now you can't practice medicine without your IT systems. If I go into the hospital and, heaven forbid, there's a downtime, then I am up a creek without a paddle. Now, there have to be, therefore, processes in place to tide you over. There will be planned downtimes. Hopefully, there will not be unplanned downtimes of any significant period of time, but therefore creating those types of resources. So how is Canada, you know, approaching some of these issues? I assume many of you know better than I, but you know, taking a look at what's in the environment and talking with people across Canada, you know, there is clearly an understanding of the importance of healthcare IT. Patient engagement on, I believe, is happening predominantly on the provincial level, where people are identifying the need for more patient engagement, use of patient portals, other means of using mobility, for instance, in order to connect with the clients, in order to ensure that they are part of that healthcare team. And that's another area where if you look at a general concept of what's going on in healthcare, it's really the generation of a healthcare team. Of course, you know, being the doctor, I have to say the doctor is the captain of the ship, but also being married for over 30 years, I know that that's not true. We know often where the power lies. But it is a true team, and by using appropriate pieces of technology, you can go ahead and enable people to, as we say, practice up to the upper limits of their licensure. So as a primary care doc, I really shouldn't have to do the annual physicals and have to do the, the blood pressure checks and things like that. I should be concentrating on the diabetic who we're having trouble managing, or the patient whose blood pressure is not under control, while physician extenders of some sorts, nurse practitioners, et cetera, can go ahead and take care of those other problems. And by using healthcare IT in ways to distribute and monitor and ensure that there is appropriate communication between all of the different members of that healthcare team, we can see a tremendous improvement in efficiency and help deal with one of those big problems that we talked about earlier, which is that ever-increasing number of patients that are now need to be taken care of with the aging population and expanding middle class. Interoperability and integration, it's my understanding that Infoway is playing a significant role there. We talked about the importance of that. And even though, again, being from the US, and I apologize for that, and everybody says, oh, well, look at the Canadian system. Well, we're starting also to see some needs for how do we readjust here in Canada as well, the payment systems, the incentive systems, how do we align incentives appropriately, and Ontario has their HBAM, the health-based allocation model, to go ahead and try some new and innovative ways of taking a fixed amount of dollars, and that was, I believe, another area we talked about, where there is only so much money, and even though those pressures are expanding upon it, we have to figure out better ways to deal with that money, and one of them is by evaluating new financial models. In Alberta, there's a physician assistant pilot program to go ahead and help with the issues and to get more educated people out there taking care of the expanding population. So, as I stated earlier, we can't address all of these complex problems and pressures that are existing within healthcare in general without healthcare information technology. However, it's not the answer to everything. We can't address it with healthcare IT alone because it is much bigger than just the technology. I don't know if you're familiar with the term of the socio-technical environment. Healthcare, really above and beyond many other areas, but this does hold true in really any area of business, is not just the technical aspects of how do we take care of it, but all of the social aspects, the change management, the education, the involvement, the changes in processes, the change management process, leadership changes, all of those things are a huge aspect, and I hope that there are people here that are either involved directly with that aspect of healthcare IT. When we first put in our clinical information system at Methodist Hospital, where I still practice part-time, we said that the implementation was about 30% technical and 70% of that larger social aspect that requires people. So never underestimate the importance of dealing with all of those human aspects of healthcare IT implementation and change. Patient engagement continues to come up, and yes, we have IT solutions to help with that, but if you have a population that is uneducated or where there are social or religious issues, cultural issues that have to be dealt with, all of those areas need to be considered and dealt with as you go ahead and develop. And so there is no cookie cutter plan to, well, how do I get patient engagement? Because it has to do so much with the environment. What's the general direction of the community? What are some of the subpopulations and ethnic groups that you have in your area? How do we go ahead and deal with that, with those issues? And those are hugely important. And in order to get a lot of this communication, we have standards. You could put this underneath the technical issue. And as you go ahead and, and look at all of this information that we are now getting into our healthcare IT, electronic medical record, electronic health record, whatever you want to call it, we've got lots and lots of data that we're getting in there. But that data has to turn into something important and something useful, and we need to turn it into information, and that's where analytics and the reporting process gets to be hugely important. And when I'm with the right audience, and this clearly is the right audience, I say that all of the work that we do for adoption and implementation and getting people to use the system, all of that is extremely important, but that is in many ways just a means to the end, and the end is the information we can get out of that. So in the 1 minute I have left before the hook, my final word is we're more alike than we are different, but we're not the same. And I must admit, I love my final picture. I'm a dog person. Actually, you'll see the Westie is the type of dogs that we have. But I mean, I think the idea here is regardless of where you go internationally, there are many commonalities that exist from one region to another. Even from one province to another, there are going to be commonalities, but there will also be differences. And we have to take those differences into consideration, but not ignore the commonalities that exist. So with that, again, thank you. My apologies again for my tardiness, and I'm see if there's any questions.
Happy to take questions. First, perhaps a round of applause for both our presenters. We have a few minutes for questions. Any particular questions you might want to ask of Toby or Stephen? Anyone? Oh, one over there.
Yes, data is plural.
John.
Thank you. So you guys are a great tag team together. And today, what I've heard is a lot of discussion about how health information technology is really starting to address a lot of chronic disease issues. And the examples tend to fall in places like diabetes and COPD and things like that. When we look at the profile, and when I talk to the physicians group where I live on Salt Spring Island, that they spend a lot of time on mental health issues and managing routine procedures with folks who either have addictions or mental health issues around them. And it's driving them past the 5 o'clock quit time, let's say that. So is health information technology helping in this area at all? Are there solutions out there right now that are addressing this gigantic piece of healthcare that seems so fuzzy and qualitative in a lot of ways?
So, yes. Next question. So there are many aspects. In some ways, it's the same response that I have here. It's the same, yet it's different. So there are aspects about mental health management that are just the same as any other chronic illness. There has to, it's something that requires ongoing evaluation. It requires understanding of what the status is. You need to distribute the care among. So, I mean, should the primary care doc be handling, all of the, psych issues that come in, or should there be a relationship with a mental health professional and, communication back and forth? So in many ways, it's the same. There is documentation that should be done, and as you said, mental health, there is a lot more, the technical term is mushiness, in what has to be documented. It's much more subjective. But that doesn't mean that there is not information that can be put in as structured data. Not everything, and I'm not at all not a believer in any aspects of healthcare IT that everything should be structured data. And so within mental health, you probably have more areas where you need to be able to put in free text, but still the same idea of being able to have all that information in a single location. There are some technical aspects that have to be dealt with, especially privacy and security. And so to ensure that the systems that you're using can wall off some of those aspects of somebody's health problems, to make certain issues private, for instance, that they don't want other caregivers to know about, et cetera. So I think that it's the same, but it's different, and we can use the same tools, but have the flexibility to mold those tools to meet the needs of that particular segment.
We have time for maybe one more question.
I can give you an insight on that as well. The state of South Australia, Adelaide being the principal city, claims to be the most rural environment in Australia in terms of the disparate communities, and they are implementing a single integrated data structure solution for the entire state, one EMR, shared many, that for which mental health is, I would call it the #1 priority in their minds. They seem to have realized that when their heads are right, and their souls are right, they heal better, they stay healthier. Do you get my drift? And we'll see how that bears out. But to my knowledge, that is the first public system where that imperative is IT enabled. There are some subpopulations in England that are building single infrastructures over large communities for which mental health is a priority. They're a little less mature at present, but will soon give us more data on what can be and cannot be accomplished. And Toby said personal privacy. I mean, you guys know that in Canada better than any economy in the world. It's the best possible and the worst possible thing to deal with.
I will tell folks, we have been doing content capture. If you've been in the telehealth or the clinician forums, we've been recording those presentations from this morning. We've also recorded this presentation, so if you'd like to see this again, or if you'd like to share it with colleagues, go to the Coach website, download it. Please do share it with your colleagues and friends. I think this has been a most informative discussion. We do have to return to our various symposiums for the telehealth and clinician colleagues in the room, and if you're with CIHI or with InfoWay or the emerging professionals, you have your workshops, which start shortly as well. There is coffee at the back of the room if you want to grab a cup before you go, but perhaps one last round of applause for Toby and for Stephen. Enjoy your afternoon. Thank you.